Institute entitled Preventing Alzheimer's. My name is Dr. Marjorie Bessel, and I'm the Chief Clinical Officer here for Banner Health, and I'm pleased to serve as your moderator for today's discussion. Before we get started and before we begin, I would like to thank all of our guests for being an important part of Banner Health and Banner Alzheimer's Institute community of patients, families, and supporters. This session is being recorded and all attendees are muted. However, there will be time for questions. We're going to ask you to submit those questions at any time during the program. You can go ahead and use the chat function and we'll share those with our presenters. We may not be able to get to all questions today, and for those that we're unable to get answered, we will provide answers as a follow-up to today's meeting. So first, I want to provide a little bit of background to you. In 2006, Banner Health established the Banner Alzheimer's Institute in Phoenix, with a mission to set a new standard of care for patients and their families while working collaboratively with fellow institutions to end Alzheimer's before another generation is lost. BAI is now recognized as a leader in Alzheimer's dementia prevention research and pioneering care strategies to provide hope and quality of life for patients and their caregivers. Today, you'll be hearing from two leaders in Alzheimer's prevention research, Dr. Eric Reiman and Dr. Pierre Tariot. Together, they are globally recognized as pioneers of Alzheimer's prevention research, setting the stage to help the field find effective ways to prevent this terrible disease as soon as possible. So again, please use the chat function to provide questions to us. I will be moderating, and we're going to go ahead and get our conversation started with Dr. Eric Reiman, Executive Director of Banner Alzheimer's Institute, Chief Executive Officer of Banner Research, and Director of Arizona Alzheimer's Consortium. His interests are many, and they include brain imaging, blood-based biomarkers, APOE and genomics research, and unusually early detection and tracking of Alzheimer's disease, the discovery and accelerated evaluation of Alzheimer's prevention therapies, and new models of research, collaboration, and clinical care. He's also an author of more than 500 publications, a principal investigator of the Alzheimer's Prevention Initiative, and of course, several NIH grants. In addition, he's a member of the National Advisory Council on Aging, NIA Council, and a recipient of multiple prizes and awards. Dr. Reiman, thank you so much, and we'll turn it over to you.
Thank you, Dr. Bessel, and thank you for all your support of Banner Alzheimer's Institute, your leadership role at Banner Health, and the remarkable job that you and our team is doing in this fight against this COVID-19 pandemic. We're extremely grateful. I'm also grateful to our guests for joining us today. In the next 15 minutes, I'd like to say a few words about the need to understand, treat, and indeed prevent Alzheimer's, the progress we're making in Alzheimer's prevention research, and the importance of stakeholders like you in our success. Could I have the slides, please? And can I have the next slide? As some of you have heard me say in the past, Alzheimer's disease is an unacceptable problem. It takes a devastating toll on the affected person. It takes an underappreciated and intolerable toll on family caregivers. And with the rapidly growing number of people living to older ages, this one age-related disorder is projected to affect more than 100 million people within the next 30 years, taking an overwhelming toll in countries around the world. There is an urgent need to find solutions to this problem today. Next slide. In the last few years, we've seen some remarkable progress in Alzheimer's disease research. We've seen researchers continue to characterize the cascade of molecular events that lead to each of the microscopic abnormalities that we see in the brains of patients with Alzheimer's disease, including amyloid plaques and tau tangles, which are cardinal features of the disease and used to help make the diagnosis, and a loss of brain cells and their connections. We've begun to understand genetic and non-genetic risk factors for Alzheimer's disease. The major genetic risk factor is a gene called ApoE, which comes in different flavors and confer different levels of risk. And we're also aware of about 250 mutations or misspellings of rare genes that cause certain family members to develop Alzheimer's disease at younger age, and for their children to inherit this disease. We've seen in the last few years better ways to characterize the molecular processes at the end of life in brain donors, and we have a world-leading brain donation program at Banner Health. We have seen the development of biological measurements in people during life to characterize some of the features of Alzheimer's disease. It's had a transformative impact on the field, and I'll say a few more words about that later. We've begun to see a more diversified portfolio of promising treatments. Most of the treatments for a while that are trying to slow the disease in its tracks have been focusing on this protein amyloid, which still have an important role potentially to play, but we have other promising treatments as well. And one of the areas that we have been particularly interested in is thinking about helping in the development of ApoE modifying gene and drug therapies to help in this regard. And we're excited about the role that we at our own institution can play in these endeavors. Next slide. For the last 30 years, researchers have been interested in the role that a protein called amyloid might play in the development of Alzheimer's disease. And according to a hypothesis that many but not all researchers subscribe to, the development of Alzheimer's disease has been suggested to begin with the accumulation of a particular form of the amyloid beta protein into soluble aggregates or oligomers and fibrils that form plaques. And these have been suggested to form the kindling that might lead to the raging fire that damages the brain, including the development of inflammatory changes, tangles in the brain that are made up of a different protein called tau, and the loss of brain cells and their connections that process information like a computer. We're still needing confirmation of this hypothesis, and Dr. Tariot will tell you a little bit about some of the efforts in clinical trials to help determine whether these anti-amyloid treatments may have a clinical benefit, providing support and helping to change the field. Next slide. I'm a brain imaging researcher by background, and there are a number of brain imaging techniques that can characterize different elements of the disease. For instance, we can use FDG PET scans to look at reductions in brain activity in certain parts of the brain that are distinctive for persons with Alzheimer's disease. We can use MRI measurements of brain volume to look at the shrinkage of the brain that accompanies the loss of brain cells and their connections. And we can measure that shrinkage in different ways as illustrated in that row. And in the last few years, we've been very excited about the development of PET scans to actually measure amyloid plaques and tau tangles in the living human brain. These and cerebral spinal fluid measures have transformed Alzheimer's disease research, but they're ultimately limited due to the expense of PET scans and the invasive nature of obtaining cerebral spinal fluid. And we've been interested in having more affordable, much more scalable biological measurements that we can apply to many more people over time. Next slide. We have been extremely excited in the last 2 years, particularly in the last few months, about the development of blood tests to provide indicators of amyloid plaques and tau tangles, the features used to help make the diagnosis of Alzheimer's disease, and also other measures of degeneration. There is now an amyloid blood test that a number of groups have been working on that is roughly about 87% accurate in determining the presence or absence of amyloid plaques. There's more work that needs to be done to establish that they are reliable when measurements are made at different times. And there was a recent blood test that will begin to be used in limited ways in the clinical setting. Our group has been helping in the development of another blood test called p-tau 217, a measurement of this protein, phosphorylated tau, which is the major constituent of tangles, and seems to be an indicator of not just tangles, but amyloid plaques as well. It appears to be over 90% accurate in the detection of plaques and tangles. And we have other measurements to characterize the degenerative changes that accompany Alzheimer's and other changes, and hopefully more tests to come. In the next 2 years, I am excited about the role that blood tests will play in transforming Alzheimer's research, the discovery and evaluation of medication and non-medication treatments, and helping to change clinical care. We have more work to do in this regard, but I anticipate once one establishes the technical performance of these blood tests and how to use them in the optimal way to communicate them to providers and patients and family caregivers, that they may begin to have a profound impact in clinical care within the next 2, possibly 3 years, that they will have even during this time a profound impact on the evaluation of treatments, and ultimately on the affordability and widespread availability of disease slowing and prevention therapies when they become available. Next slide, please. While there has been wonderful progress made in the last few years that give me excitement about the opportunity to find new targets at which to aim treatments, new treatments themselves, and put them to the test in clinical trials, we've had some challenges in clinical trials over the last number of years. We have not yet had an approved new treatment for Alzheimer's disease since 2003, even though we have a number of promising disease slowing treatments that are designed to not just address the symptoms that occur, which are important in themselves, but possibly stop the progression of the disease. You may have seen in the news consideration of possible approval of an anti-amyloid antibody therapy called aducanumab from Biogen. And this has been a treatment that can reduce amyloid plaques in the brain rather dramatically. There are a couple of other antibody treatments that will be following in its footsteps. And there were some studies that were designed to try to definitively show whether they would slow down cognitive decline. Unfortunately, these studies were stopped early due to a mistaken belief that they were unlikely to have a clinical benefit. And despite that observation, stopping the studies early, 1 of 2 trials was suggested to have a benefit. So the field now is trying to grapple with the idea that we have a treatment that may be reasonably likely, but not completely certain to have a clinical benefit, that may have significant expense, an unmet need on the part of patients and family caregivers, and might there be a way to think about its provisional use without interfering with the further opportunities to establish more fully its clinical value and the clinical value of other treatments that are underway. So there's a lot of discussion happening. Dr. Tariot will tell you a little bit about that. I am very excited about new developments, giving us the opportunity to look at new drug therapies, emerging gene therapies, including in the near future, ApoE gene silencing treatments, as well as non-medication treatments, and more powerful ways to inform whether they are likely to work. Next slide, please. Our group has had a long-standing interest in prevention for a couple of reasons. First, we believe that some of the disease-modifying treatments that have been developed may have a better chance to show a benefit if they are started before people develop symptoms, when the disease may have already ravaged the brain and may be more like metastatic cancer than the treatments that that would have a clear and easier chance to have a benefit. It has also been suggested that because the frequency of Alzheimer's disease doubles every 5 years after the age of 65, that an even modest disease delaying therapy, one that delayed the clinical onset by only 5 years, could reduce the number of people who get the disease by half. And we hope that we'll have an even more profound benefit from that. So there's a very important need to find prevention therapies. And when we established Banner Alzheimer's Institute in 2006, we asked ourselves, suppose a treatment out there already worked. It would take too many healthy volunteers, too many years, and too much money to evaluate a prevention therapy in healthy people, waiting for them to see who goes on to develop symptoms. So we have developed strategies to use biological measurements and more subtle cognitive measurements in people at genetic risk or based on their biological measurements are at risk. We've tried to establish the scientific means to rapidly test treatments, the means to support their accelerated approval and availability. And with the advent of new developments like blood tests, hopefully the opportunity to find affordable and accessible ways to make these treatments available when they come. Next slide. A common question we get is, what might I do today to reduce my risk of developing cognitive problems as I get older, including but not limited to those associated with Alzheimer's disease? And we often talk about a number of otherwise health-promoting treatments that may have a benefit, but because they have other health-promoting benefits and may not hurt, we recommend, even without the most compelling evidence at that time, be physically active. Treat your hypertension, your high blood pressure, your high cholesterol level, and diabetes. Engage in a healthy diet. Be socially active, but not quite as active at this particular time. Use alcohol in moderation. It's been suggested that losing weight and stop, particularly in middle age, and smoking cessation may benefit. And there have been other suggestions as well. Next slide. There are a number of different lists that you may see of what has been suggested to be beneficial. And I happen to like the list that was recently described by the World Health Organization, and which I've adapted in this table, because it gives you some suggested recommendations to promote cognitive health and reduce the risk of cognitive decline. It gives you information about the quality of the evidence that actually supports this at the time, which isn't always compelling. And it gives some information about the recommendation based on both the evidence and the other health promoting benefits. One interesting study called Sprint Mind looked at the effects of reducing blood pressure, systolic blood pressure, to 120 instead of 140, which has now become the established goal. And they found about a third fewer individuals went on to develop mild cognitive impairment. Research like that is very important, even while we're looking at disease-stopping treatments. Next slide, please. So my colleagues, Pierre, Tariot, Jessica Langbaum, and our colleagues at Banner Alzheimer's Institute established the Alzheimer's Prevention Initiative to help launch a new era in Alzheimer's prevention research, establish enrollment resources and engagement opportunities to let you know about the opportunities at hand and support the participation in trials, to establish new research paradigms to study individuals at genetic or biological risk for Alzheimer's disease, and to find out whether these treatments work sooner than otherwise possible, and to support their approval along the way. Dr. Tariot will tell you about resources we've developed, extremely large registries, for instance, to support enrollment in studies. We got NIH support for the first funded prevention trials, including a prevention trial in the Medellin, Colombia area, in people who carry a rare misspelling of a gene are virtually certain to develop Alzheimer's disease at younger ages. And we're studying them with an anti-amyloid treatment close to their age at onset. We'll read out the results of that study in 2022. We started other prevention trials in people who carry 1 or 2 copies of the ApoE4 gene, including those with or without amyloid plaque burden. And unfortunately, while we were studying an oral medication called a BACE inhibitor that might be beneficial, as well as a vaccine therapy, we and others were forced to discontinue the study of these treatments due to an unexpected, mild, but fortunately reversible side effect, mild memory worsening unrelated to the disease itself. We are very excited about the opportunity with a new grant to study cognitively unimpaired individuals who have amyloid plaques, as 25% of older adults do, and maybe have the chance to find and support the approval of a prevention therapy by 2025. Next slide. As our family members in Colombia remind us every day, our families are waiting, and we just want to underscore the urgency to address this problem as effectively as we can and as soon as we can. Next slide. As we look ahead, I'm excited about opportunities to change the way care is provided, potentially within the next 2 to 3 years, possibly find disease-modifying treatments during that time, and possibly find effective prevention therapies within the next 5 years. I'm also interested in the opportunities with new scientific tools to find other kinds of disease-stopping treatments. Next slide. None of our progress would be possible without our valued research participants. None of it would have been possible here at Banner without Banner Health Foundation, Banner Alzheimer's Foundation, and without the extraordinarily generous support of passionate, informed stakeholders like you. My colleagues and I couldn't be more grateful, and we couldn't be more determined to make a difference in the fight against this terrible disease. Thank you very much.
Thank you, Dr. Reiman, and really appreciate that overview. Certainly, it's not a surprise that you are a recipient of so many awards, including the Potamkin Prize for the research and your dedication to this field. Now, I do want to remind everybody to go ahead and use the chat function to submit questions. You can send them to everybody, or you can send them directly to me, as I will continue to moderate. So Eric, we do have a couple questions that were sent to me privately, so I'm going to go ahead and have you answer a couple of those before we move on in our program. So the first one is a really good one. You talked about both prevention as well as some focus on cure. It feels like to this viewer that perhaps the focus is more on prevention than cure for those who already have the disease. Can you comment on how that research and your focus of energies is currently divided?
Thank you for asking that question. Dr. Tariot will give you a sense of where our focus is, including a large number of trials in clinically affected patients, as well as our interest in intervening as early as we can to make a difference there. We need to have that marriage between help and hope, research and care, and find treatments for clinically affected individuals. As Dr. Tariot will describe, we may see a treatment for an important problem not associated with cognitive decline itself get approved soon. Dr. Tariot had a leadership role in that study. And we're waiting to see what happens with the drugs like aducanumab and other antibody therapies in terms of whether they could help to slow down the progression of symptoms, to give more time to patients and family caregivers and improve their quality of life. We'd like to be able to do that while we also address a range of medical and non-medical needs to promote the quality of life, even when we can't slow the progression. The story with aducanumab is interesting, and I will leave that for Dr. Tariot.
Thank you so much for that. Next, another private question. This viewer on our program this afternoon has actually several family members with the disease. Certainly you're very familiar with how this terrible disease can run in families with the research that you've been doing in Colombia. This particular individual wants to know if they should get tested for the disease.
Well, thank you for that question, and my heart goes out to you for what you and your family is going through. As someone who has also been affected with family members with the condition, this is a problem that takes a toll on everybody, and we need to find a ways to address this. I get this question a lot because I've been studying this genetic risk factor, ApoE, for quite some time, and I'm asked about the possibility of testing, either genetic testing or increasingly biological testing, say with amyloid PET scans or blood tests. Right now, while we are excited about those technologies, with regard to the biological tests themselves, a PET scan or blood tests, they may have a role in clinically affected individuals who already have memory and thinking problems, particularly if that information could be used in a way to help people make this proactive decisions about medical and non-medical management. We do not recommend them at this time in unimpaired individuals because they don't tell us with sufficient certainty whether or when they might develop symptoms or what they could do about it at this time. But we do envision a time, let's say we had a prevention therapy that actually worked, which is, I think, possible. I think we have a fighting chance to find and support a prevention therapy by 2025, and there are non-medication strategies that might be helpful as well. What if we found a treatment that worked? We might be able to use a blood test every 2 years after the age of 50 to screen individuals and give them information about what they could do in that way. I'm also hoping that those blood tests could also be used in clinically affected individuals to reach out to more people and remind them of the things they could do right now, even while we're waiting to find disease-stopping treatments.
That's great. And thank you, Eric, so much. The wonderful table that you had there of things that all of us can do for healthy living that can have some impact on the disease was a good reminder. I'm going to do one more question before we move on. And again, everybody keep bringing the questions forward, and whatever we don't get to, we will follow up with. So this one is a little sports related, Eric. So favorite sports team to the side. There is a lot of talk about retired NFL players getting Alzheimer's at a greater rate. Can you just provide some commentary on that?
So I'm one of the principal investigators of a national study that is looking at the biological changes in life of retired NFL players and retired college football players. And studies that have looked at individual retired football players who've had cognitive problems or some behavioral challenges, who have come to autopsy, they have found a feature in their brains, the kind of tangles we see with Alzheimer's disease, in unusual parts of the brain and without amyloid plaques on board. And they call that condition CTE, or chronic traumatic encephalopathy. So those findings have led to a concern among all of us about what we should do when it comes to contact sports in general for our children or others. And unfortunately, at the moment, the concern and fear has outstripped the science. So what we need to do now is to see whether we can measure those same changes in life. And we had a paper in the New England Journal of Medicine out of Arizona and Boston about 1.5 years ago, suggesting we might be able to see subtle hints of these changes in the brain. And more importantly, we need to determine whether those changes are meaningful in terms of predicting cognitive decline or not. Until we do those studies, complete those studies, we don't know for sure, but it's still important to take the right kind of precautions along the way. And I would suggest that for my children or family members.
That's great. Thank you so much. Well, again, just a wealth of information, and thank you, Eric, for your continued dedication, your lifelong professional dedication to this field. Next up, I do want to make sure that we continue to allow enough time for our next speaker. Next up is Dr. Pierre Tariot. Dr. Tariot serves as the director of Banner Alzheimer's Institute. He's board certified in internal medicine and psychiatry, and also has added qualifications in geriatrics. His work has focused on care and study of people with and at risk for Alzheimer's, with a special emphasis on design and implementation of clinical trials for prevention and treatment, development of biomarkers, and demonstration of effective dementia care. Like Eric, he is a prolific publisher and has over 400 papers on these topics, including articles regarding studies that have led to FDA approval of new medications. He also serves as co-director of the Alzheimer's Prevention Initiative, API. His research affiliations include the National Institution of Aging, NIA, the NIMH, and the Alzheimer's Association. Pierre, off to you.
Thank you, Dr. Bessel. Thanks for all of your hard work and service. The leadership of Banner has been just incredible during this crisis. So thank you in particular and your colleagues. Thank you, Eric, for a great talk and being such a great colleague. My wife, Laura, and I moved here 15 years ago with a shared dream that Eric had as well of setting up an institute like this. Would absolutely not have happened without the full support of Banner Health and our incredible donors, as well as government agencies such as the National Institutes of Health. So maybe we can go to my slides to continue the sports theme here. The World Series just ended as I was making my slides, so I put a little bit of a baseball twist on things. As far as football goes, I would suggest that you don't play professional football and don't get in the ring with professional boxers. So I want to talk about whether we can strike out Alzheimer's disease. So let's go to the next slide. And a little bit of what I'm going to say may overlap a bit with Dr. Reiman's talk, but I think that's okay. So when you think about risk factors, we tend to think about risk factors for people who get the disease very early in life as opposed to later in life. By early, the textbooks say younger than 65. In reality, we think younger than 60. The textbooks say that it's about 5% of Alzheimer's patients who fit in this category. The reality, as I see it, is it's far less. The major causes of this type, this early onset form of disease, Eric mentioned, these rare genetic mutations that lead with virtual certainty to the onset of symptoms at a young age, as well as persons with Down syndrome who develop Alzheimer's changes in their brains quite young. From a scientific standpoint, it's been a big deal to learn that all of these genetic findings contribute to misprocessing of the amyloid protein, the amyloid pathway. Hence, that's part of the driver of the focus on anti-amyloid therapies. Next slide, please. In terms of risks for late onset Alzheimer's disease, age is a major factor. Let's go to the next slide. It's one of the biggest factors. So, for instance, just to put this in context, you don't, I guess we can't do this interactively, but what was the average life expectancy in the US when the Constitution was drafted? Most people have no idea. People guess all over the map. If you hit the next build, that'll give the answer. It was 36 years average age at death then. The median age of 16 means that there was a lot of death in infancy. Here's another interesting one. Of all the people who've ever inhabited the planet, what percentage of those people are alive today? Go ahead to the answer, 2/3. And then lastly, when Social Security was launched, what was the average US life expectancy? Some people get this right. Yeah, 62. So the point here is that we're aging successfully. And as Eric pointed out, that the irony is that makes us susceptible to common age-related conditions like Alzheimer's, also osteoarthritis. Next question. Next slide. Ignore the shading here. Just look at the heights of the bar. This is by age groups. The likelihood that U.S. Citizens would have Alzheimer's disease. So between 65 and 74, it's maybe 5% of us. 75 to 84, that jumps to almost 20%. And 85 and above, you see that nearly half of us will have a disease like Alzheimer's disease. So that's a lot. So if all I know about the person in the waiting room that I'm about to see for the first time is that she's 85, I'm already going to be worried about this possibility. Next slide, please. In terms of other risks besides age for late onset Alzheimer's, Eric talked about this important gene that he's had a lot to do with understanding, the gene that leads to the production of the APOE protein, apolipoprotein E protein, which is a cholesterol chaperone but has lots of other functions as well. So you get one copy from your mom of the gene that codes for it, one from your dad. Comes in 3 flavors, 2, 3, and 4. We'll have to ask Eric later what happened to 1. But the takeaway is if you have 1 copy of the APOE2 gene, your risk of getting Alzheimer's jumps about 3.5-fold. And if you have 2 copies, your risk jumps about 35-fold. It's not causative, but it's a major risk factor. And I'll mention in passing, I can't help myself but mention a rare mutation that leads to reduced risk called the Icelandic mutation, also blocks amyloid dysregulation. And then the other point here is that the APOE2 flavor gene reduces risk. Eric had a major paper on that just recently. So the overall view of risk for later, or the more common form of late onset Alzheimer's disease, is that age is a biggie, genetics is a biggie, and then a combination, next slide, of lifestyle and environmental factors. Some of the same points that Eric made. I think I would summarize this by saying a heart-healthy lifestyle is a brain-healthy lifestyle. Don't play professional football, don't get in the ring with a professional boxer, don't cliff dive, and aerobic exercise I have bolded because that is probably most strongly supported by evidence. We're almost at the point where insurance companies may actually fund healthy lifestyle programs for their beneficiaries because the evidence is so strong that that can help with brain health. You've heard of silver sneakers. I've dubbed this silver synapses. We'll see if that comes to pass. Next slide, please. Eric talked about the bad boy proteins that are characteristic of the disease, the amyloid plaques that look like sort of bubblegum deposits outside brain cells when you look at them under the microscope. And then these tangly, ropey deposits inside cells caused by abnormally processed tau protein. There are lots of other changes as well. This is actually a picture of Dr. Alzheimer's first patient, Auguste, and photomicrographs from her brain. Believe it or not, she was in her 50s when that photograph was taken. Next slide, please. Eric has been a major leader in the development of all kinds of tools to assess the health or disease status of the brain and track changes over time. So if you go with me from 5 o'clock around the horn here, we have tests of memory and thinking, daily functioning. We've got all kinds of genetic risk assessments that we can do. At 7 o'clock, we've got these PET scans to look at amyloid and tau burden, which is amazing how quickly that developed. Eric's been a leader at 11 o'clock here in the development of glucose PET scans to look at a pattern of how the brain is using its fuel that's specifically abnormal in Alzheimer's disease, even before symptoms emerge. And I won't repeat what Eric said about fluid biomarkers in the blood and spinal fluid, but this is probably going to be a major game changer in our field. And then we can use MRI technologies to look at brain structure and volume and pathways, how they're functioning. Next slide, please. I want to just hit on some of the emerging therapies. I'm not going to talk about the current FDA-approved treatments. As Eric mentioned, nothing new in 17 years. That doesn't mean they're not important. They are, but we'd like to do better. And I won't read this list, but the bulk of the agents that are in clinical trials address amyloid or tau dysregulation, but there are lots of other ones as well. And I'm going to hit on just a few examples. Next slide, please. So with our currently available therapies, the idea is to help people's brains function better for longer so symptoms are less and progression of symptoms is slower. We could imagine disease-modifying therapy that only slow the progression of the disease but don't cause any bump upward in function. We could imagine therapies that arrest the decline in thinking ability or functional ability. We actually avoid using the word cure, but this isn't my slide, so it's on here. Cure is a very high bar, and difficult to recognize. For instance, by the FDA, they would say, "How would you know that the person's disease has been completely taken care of and would never ever come back?" So these are the kinds of things we're thinking about as we look at new therapies. Next slide, please. Eric talked about aducanumab. Now, bear with me for a second. So there are sort of, in the black box, there are two columns depicting four individual persons' cross-sectional PET scans looking at amyloid. There's the baseline series you see where there's a bunch of orange and red, which is bad. And then you see a column 1 year inside the black box. These are individual patients in an early trial of aducanumab. And the takeaway here is if you look at the pairs of PET scans in the placebo group, the orange is about as bad. If you look down at the next three pairs of brains, you see a lot of orange and red at the beginning and much less after a year. That's evidence of amyloid being removed from the brain by this immunotherapy called aducanumab. This was a startling finding, and the first ever proof that you could actually remove amyloid from the brains of persons living with Alzheimer's dementia. Next slide, please. So the company Biogen went ahead and did a global phase 3 program launched after that study that I just talked about. There's the word "after" missing here. Then a flawed interim analysis was done that Eric mentioned, that it looked like to an independent committee that the trials weren't likely to show benefit. They were stopped, but while they were being wound down, additional data came in, and whoa, in October 19, Biogen said, whoa, we have a positive result here, at least in one of our studies, and then not in the other. This is confusing. And FDA, when I made the slide, it was before November 6th, so the FDA convened an advisory committee last week that was kind of ticked off at the way the meeting was handled and gave a bit of a thumbs down to further advise the FDA not to approve aducanumab based on these data. I personally think there's a high likelihood that some middle ground will be found, and it may be sort of conditionally approved for use while further studies are going forward. So it remains to be seen, and we'll know for sure by March of 2021. Next slide, please. Again, ApoE has Eric's name all over it. We've explained that it's such a big risk factor. So really the takeaway from this trial, slide, got trials on the brain, it is that ApoE itself is becoming a very, very attractive target. And a lot of the edgy new therapies to attack ApoE as a target involve very brand new technologies that we need even more expertise to help us with as we consider implementing studies. So some of you may know that we've recruited a major player from the pharmaceutical industry to join us, Dr. Bob Alexander, to help us plan and implement these kinds of cutting-edge studies. Next slide, please. Eric mentioned the SPRINT MIND study. The basic question was, would more intensive blood pressure control result in better long-term brain health than standard blood pressure control. The primary outcome from the study was actually negative, but a secondary analysis that's also very important showed that there was about a 19% reduced risk of combined cognitive impairment. It's the first time something like that has been shown, so I still consider it a major milestone. Next slide, please. And turning into the home stretch here, there's some fascinating new therapies out there, primarily for persons already affected. There is a microbiome-derived drug that's been approved for use in China for persons with symptomatic Alzheimer's, and it's just getting off the ground in the US in a phase 3 study. There are ideas about light stimulation to the brain, magnetic stimulation, ultrasound. These sound kind of wacko, but actually once you learn the details, there's a there. They deserve to be looked at. Next slide. So here's my scorecard. It's quite idiosyncratic. I would say that the grand slam would be significantly delaying the onset of symptoms or even preventing onset of symptoms. There was a question about why such a focus on that. We think it's more plausible to stave off brain changes than reverse them once they've occurred. So that's part of the drive for the emphasis on prevention. I didn't mention a medicine called pimavanserin, which is under review at the FDA right now for approval for marketing for psychosis associated with all forms of dementia. We can get into it further a bit later if you'd like, but this would be a huge deal if this happens, because the FDA has never recognized the effectiveness of any treatment for the major emotional and psychological changes that can occur with diseases like Alzheimer's. Is aducanumab a triple, or down below I have it as a possible foul ball? It remains to be seen. If it's approved, it'll signify a major advance, and it will be the first of several drugs like it. Double, maybe this microbiome-derived drug from China. It is approved in China, so it's gotten that far. There's some other anti-amyloid antibodies. I think biomarkers are proving to be a big deal. The lifestyle results are increasingly persuasive of being important. Sprint mind, we need more evidence like that to be more sure that approach really is going to work. The knuckleball, the way I conceive it, is a game changer, which is why I put the blood biomarkers there. Eric mentioned that a whole class of agents flopped, much to our chagrin, the so-called BACE inhibitors. And then there are a bunch of fascinating therapies on deck. So my last slide includes a thank you to all of you, and again to Banner and to our foundation colleagues. We do need volunteers for observational as well as interventional studies for treatment or prevention. We have a phone number that works at our institute for people who are interested. Jessica Langbaum led the creation of a nationwide online community called the Alzheimer's Prevention Registry. We have hundreds of thousands of people on that program, and you could think about joining. It has wonderful content that you get every couple of weeks, and under that umbrella, she created an at-home genetic testing program to help enrich research referrals. That's called Gene Match. And lastly, again, thank you. And as Eric said, this body of work would not have happened without your support and the support of Banner Health. So thank you. Dr. Bessel, back to you.
Thank you, Dr. Tariot. It's such a wonderful overview of all things that are in play and what might the future lead us to. So I do have a couple of questions that have come in, and so I'll ask first to Dr. Tariot, and then Dr. Reiman, you may have something else to add. So first of all, you mentioned a drug that has been approved in China, And so really question is what's happening in the United States? Why is the FDA not approving the same drug? Why is that not in our armamentarium for this disease?
That's a great question. The Chinese Health Authority rules for approval for marketing are different from the FDA's. So that's the main answer. And that's true actually around the globe. So for this drug to be approved for marketing in other countries, it would need to pass a higher hurdle. At least one more large study showing a win in terms of preserving ability to think better, but also function better. Eric was involved at arm's length in some of that work. But the bottom line is that the standards are different in most countries, including the United States. So I give credit to the company called Green Valley for launching a global phase 3 program.
Thank you for that. Dr. Terry, I'm going to have you do this next one, and then Dr. Reiman, maybe you'll have something else to expand on his answer. So, you know, you both covered a lot of material here and showing us that there are different genetic and environmental factors, all of which can potentially be involved and affect the onset of Alzheimer's dementia. So when thinking about therapy, do you think there is going to be, you know, one silver bullet for everybody? Do you foresee that there'll be multiple therapies that have to be tailored? Please, you know, put your forecasting hat on and see if you can provide us some insight into what the future will look like. First, Dr. Tariot, and then Dr. Reiman to follow, please.
Well, I'm dying to know if we say something similar or different here, so I'm happy to go first. I think a cocktail is more likely. The brain is a pretty complicated organ to begin with. We're all unique to begin with. Alzheimer's disease and diseases like it are complex and affect each person's brain in a unique way. So on the one hand, it's I would say likely that certain important disease-modifying therapies will be beneficial for many people. I predict that we may need, if you want to call it a combination approach or a cocktail approach, to be most effective. I could elaborate, but Eric, what would you say?
Well, thanks, Pierre, and thank you for that terrific presentation. You know, I share that view. I think Alzheimer's will follow the model that we're seeing in cancer, a more precision-based treatment. I'm hopeful that there's a final common pathway that if you, now, no matter how you enter that pathway, that you could have a benefit. But I do think that there will be differences in both the beneficial response and the potential the side effects to a given treatment, as we are already seeing with a drug like aducanumab, with a little bit more of a reversible side effect that we see, for instance, in ApoE4 carriers, and possibly a slightly greater benefit. So I can imagine the possibility that based on genetic information or biological information, we may be able to further inform the efficacy of treatments. Regarding the issue that Pierre brought up with regard to combination treatments, if you could, you know, again, I tend to overuse analogies. And if you think of Alzheimer's as both the kindling with that initial amyloid state and the fire, the subsequent pathological changes, it would be great to have a combination therapy that simultaneously extinguishes both the kindling and the fire. There are certain challenges with regard to how do those combination studies get done. You have to first demonstrate the safety of the individual treatments. But I think we can see a time in the future in which we will have combination treatments, treatments that are tailored to the individuals. It would just be great to start with that first established disease-slowing treatment, because a lot of good things will follow from that.
Yeah, and Dr. Bessel, if I may, because the person brought up genetics, you know, here's a startling example of how complicated it is. Identical twins, as they age, it will, in some cases, you know, one of the twins will develop Alzheimer's and the other might not, either ever or for another 20 years. So genetics is a big part of it, age is a big part of it, but there are other things going on. So no matter what though, eat a healthy diet, get some aerobic exercise, and wear your mask.
Right. If I can just come back to that, since I'm so commonly asked this question. First of all, it has been suggested that genetic factors account for about 70% of a person's risk, leaving plenty of room to figure out ways to address this problem or delay the onset with those non-biological or genetic factors. But I'm often asked, I have a parent who's been affected with Alzheimer's disease. They, for instance, have the, what is my risk because they developed the disease? And one of the questions that I tend to ask first is, how old were they, the affected person, when they developed symptoms? Generally, one's own risk of Alzheimer's is higher if their family members develop symptoms at a younger age, say before age 70, than after age 80. After age 70, such that in those people who have symptoms after age 70, it's a good news, bad news story. The good news is your risk may not be that much greater than other people, but as we age, all of our risks are there, and that's why we have to address this problem now.
Thank you so much. So Dr. Reiman, Dr. Tariot, a wealth of information, a wealth of forward-thinking information, and hopefully for all of those that have been able to attend here today, some really good information on what is on the horizon here. I personally have been able to refer patients to your wonderful clinics, and I just can't tell you how much appreciation the family members have, the patients have, to be able to really achieve world-class care. So for all of you that have been able to join us today, I do want to thank you for participating in our virtual program. We hope that all of you have found this information to be just incredibly informative for whatever aspect of this disease you're interested in, whether you have a personal interest related to somebody in your family or a professional interest of your lifelong work. We want to be here for you. We want to provide this information to you and for you. I also want to thank everyone for the questions that we've gotten. I'm sorry that we may not have been able to get to everybody's questions. We will certainly do a follow-up email to all of you who are registered attendees. We'll provide you a link to the recording of this session, along with a link to the Alzheimer's Prevention Registry website. We ask you, of course, to feel free to share this information. We're going to go ahead and call it a wrap this afternoon. Stay well, take care of yourself, and as Pierre said, you've got a lot of good lifestyle modifications to put into your everyday life, and we hope that you take those into consideration, and we'll be with you soon. Take care. Bye-bye.
Thank you.